Dr. Shishir Murarka, MD, Fellow of American College of Cardiology. He is Clinical Associate Professor at Banner University Medical, which is affiliated cardiologist of Arizona, Phoenix in USA. For the session, chairpersons are Dr. S.C. Datta sir, Senior Consultant Physician and Cardiologist at Ranchi, Dr. Amrit Kejriwal, Professor Internal Medicine, MGM Medical College, New Bombay. He has numerous research and consultant interventional cardiologist at Ahmedabad, and Dr. Indira Panda, clinical cardiologist at Bhubaneswar. I request Dr. S.C. Datta sir to kindly introduce our speaker, Dr. Shishir Murarka. Satish Chandra. Audio connect. Sir, Dr. Datta sir, your audio is not yet connected.
Vineet, can you hear me and can you guys see me?
Yes, you are audible.
Perfect.
I will just request S.C. Datta sir to introduce yourself. He is just... We need to just hold on. He is just connecting himself. His audio is going to be on. उनको लॉग आउट करके वापस लॉग इन करने बोलें. Sir, Dr. Satish sir, are you audible? Am I audible to you, sir? Oh, तो कैसे करें हम लोग? सर को co-host तो बना दिए हम लोग. Just a minute, Dr. Murarka. He is just coming online. He is online. Actually, some technical difficulty is having.
No problem.
Sir, am I audible to you, Satish sir? Datta sir, am I audible to you?
Yes, yes. Are you?
Yes, sir. Now you can introduce Dr. Shishir Murarka sir. And you can introduce the topic of his presentation.
Just a minute. Can you hear me and can you?
Yes, sir. You are audible now, sir.
Can you see me?
Yeah. Yes, sir. Your picture is here on the screen, sir.
Okay. Just a minute. Well, let me at the outset thank the JACC for bestowing the honor of chairing the session to me. And good morning, everybody. The current session is on aortic stenosis, and the speaker is a distinguished one from the Arizona, Phoenix. He's an associate professor, Banner University Medical Affiliated Cardiologist, and he is to deliver his address on aortic stenosis. Over to Master Dr. Shishir Murarka.
Well, first of all, good morning, everybody, and thank you again for this opportunity to speak at this conference. It's really a privilege and honor to be part of this conference. Let me try to share my screen so that you guys can see the slides. Share screen. Okay, perfect. So can you guys, are you able to see the screen?
Yes, yes, it's available.
Okay, perfect. So again, I'm going to talk on the topic of aortic stenosis. The reason I wanted to speak on this is that this topic, aortic stenosis, has, in general, structural cardiology has assumed a lot of importance in the recent times, mainly because of transcatheter aortic valve replacement. Traditionally, surgery was the only option for aortic valve replacement, and patients who were at high risk for surgery, they were denied the surgery for high risk or prohibitive risk. So in the recent times, with the introduction of TAVR or transcatheter aortic valve replacement, this is something that has assumed increasingly more and more significance in recent times because patients don't have to undergo big surgery. It's an overnight procedure. It's a procedure and the patients stay overnight and they get discharged home the very next day. So this topic I've chosen, I wanted to give a brief overview on aortic stenosis. I'm going to talk about a little bit basics of aortic stenosis. And then at the end of the presentation, I have quite a bit of slides on how to manage aortic stenosis and what are the treatment options available in this day and age.
Sorry to interrupt. May I request Dr. Murarka to kindly go for full screen mode?
Full screen mode. Let's see. How do I do that?
On the right side, lower hand, there will be 3 small icons, of which one of them will be full screen icon.
Full screen. Let me see.
If we see your slide, there is something written notes, then comments. After that, there are 3-4 small icons made. Here.
Let me see. So let's see. Slideshow. Are you able to see full screen now?
No, not yet.
Not yet. Hold on. Let me do this thing. It says full screen here. From beginning, from current slide.
Not at the top, Dr. Saab. It's at the bottom. It's at the bottom. The slide is there. Below that, there is a white strip on which there is written notes, comments.
I know what exactly you're saying, but when I am here on a full screen mode, slideshow mode, I can see the entire screen. I don't see that notes on mine.
Never mind. We'll go ahead. Thank you, sir.
Let's go ahead.
Let's go ahead. Thank you.
So just a little bit of epidemiology portion. Aortic stenosis affects around 5% of the adults above the age of 65 years of age. And as people age, the prevalence of aortic stenosis increases quite a bit. And in general, aortic stenosis is most common valvular disease in this side of the country or in this part of the world. And its prevalence is also increasing in countries with rheumatic heart disease, especially because the rheumatic heart valve disease is on decline. So as people age, you are seeing more and more degenerative aortic stenosis because of calcified aortic valves. It is common more in men than women. And in the United States, the prevalence in people who are more than 75 years of age is about 12%. And out of that 12%, severe aortic stenosis is present in about 4% or 3.5% of the patients. And the starting number to look here is around 75% of these patients are symptomatic. And only 40% of these patients, they're denied any treatment. So only 40% of the patients are treated surgically or nowadays with TAVR, and 40% of these patients are denied any sort of surgical intervention or any sort of transcatheter intervention. So 40% is a pretty good number, that are left untreated. Mortality in patients who have severe aortic stenosis at 2 years is more than 50%. Its starting rate is 50% at 2 years if it is left untreated. And unfortunately, many patients with severe aortic stenosis at the time of diagnosis, they don't have any symptoms at all. So as treating physicians, sometimes there's always a confusion. Should we treat these patients? Should we not treat these patients? What should we do next? So just an overview of normal aortic valve. The area is around 3 to 4 centimeters squared. The normal transvalvular gradient is less than 5 millimeters mercury. And the velocity across the aortic valve is less than 2 meters per second. And it's a tri-leaflet trick. And on the pictures on the slide, you can see that this is how the normal aortic valve looks like. Now, when it comes to etiology, there are various etiologies. There's congenital and acquired. And congenital, the most common etiology that we see is bicuspid aortic valve. And typically patients who are younger, you can see aortic stenosis in much younger population in those who have congenital issues, especially bicuspid aortic valve. But they tricuspid, quadricuspid, whatnot, but most common is bicuspid aortic valve. And then the majority of them that we come across is acquired. And in acquired category, there's degenerative calcification, rheumatic heart disease. These are the two most common. Degenerative calcification, obviously, it's a component of aging process. And it's usually seen in 7th to 8th decade of the population, or when they're reaching their 70s and 80s. And also they have concomitant coronary artery disease. Rheumatic heart disease we can see in younger patients who have rheumatic heart issues at an earlier age. And then there are rare causes which which are for textbook purposes, but we don't see them very commonly: SLE, rheumatoid arthritis, post-radiation, all these causes. So again, to reiterate my point, usually patients under 70 years of age, majority of them have congenital or rheumatic causes. Patients who have patients who are more than 70 years of age, not because of degenerative causes, calcified aortic valve. A little bit of insight into the pathophysiology portion, because rheumatic versus degenerative, a little bit pathophysiology is different. In rheumatic heart disease, you can see mostly adhesion and fusion of the commissures, as seen in this picture. Healing and scarring of inflammatory process.
Sorry to interrupt, Dr. Murarka. I'm sorry to interrupt, Dr. Murarka. Somehow your slides are not changing. I guess you need to stop sharing your screen and reintroduce the screen.
Reintroduce, okay, let's see. Okay.
Yes, I guess now it's okay.
Hold on, let me see if I can change the slide. Oh boy. Hold on, let me new share, because I'm not able to now. Let me see, stop share. Let's see, share screen. Share screen. Okay, Vineet, can you see my slides changing now?
Yes, now it's changing.
Okay, let's put this skeleton. I know it's not a full screen, but I think just for the
issues. But I have a request. But I have a request. Can we start all over again?
Okay, I'll just go quickly through whatever I went.
Thank you so much.
No problem. So, okay, let's do it. So again, aortic stenosis, 5% of adults, mostly above age of 65 years of age, and prevalence increases as the age increases. And we are talking about mostly degenerative aortic stenosis right now because the prevalence seems to increase as the age increases. Mostly in Europe and US, the most common cause is degenerative or calcified aortic valve causing aortic stenosis. And countries like South Asia, India, Pakistan, Sri Lanka, rheumatic heart valve disease is more common. So that is more common cause of aortic stenosis. However, we are seeing more degenerative aortic stenosis as the incidence of or the prevalence of rheumatic heart disease is on the decline. Severe aortic stenosis in patients who are more than 75 years of age is present in about 3.5% of the population in this part of the world, and about 80% of them are symptomatic. And as I alluded to earlier, only about 40% of these patients are able to be treated in any form surgically or these days with transcatheter aortic valve replacement. Mortality at around 2 years is about 50%. So that's a staggering mortality in older population. 50% mortality at 2 years for symptomatic AS, unless the valve is replaced promptly. However, as many as 50% of patients with aortic stenosis, they do not receive any treatment. They are considered too old, they are considered prohibitive risk for any intervention. So quite a majority of these patients do not receive any form of treatment. Normal aortic valve, just a very, very brief outline, 3 to 4 centimeters square is the area. The transvalvular gradient is less than 5 millimeters. And the velocity across the aortic valve is 200 centimeters per second or 2 meters per second. This graph is important, or this figure is important, because majority of the diagnosis of aortic stenosis is through echocardiographic parameters. And these are the numbers that we look for a normal aortic valve. And we will go into mild, moderate, and severe in a bit. Etiologies for aortic valve, congenital and acquired. Congenital, most common that we see is bicuspid aortic valve. And in these patients, typically aortic stenosis happen at an earlier age. When you see a younger population, it is considered bicuspid aortic valve. The other category of aortic stenosis causes is acquired, which is either degenerative or rheumatic heart disease. Degenerative usually occurs in 7th to 8th decade, and usually associated with age, coronary artery disease, patients who are on dialysis because of severe calcification. The other category is rheumatic heart disease, which will go again in pathophysiology of rheumatic heart disease as well in a bit. Patients under 70 years of age, majority of them have a congenital causes, and patients who are more than 70, majority of them have degenerative causes. All right, so rheumatic heart disease, as we were talking, the main difference between rheumatic and degenerative heart disease or aortic valve stenosis is the pathophysiology. In rheumatic heart disease, we typically see the commissural fusion because of inflammation. The fusers, the commissures here fuse together because of the inflammation, and that leads to healing and scarring during the acute phase of rheumatic heart disease. That leads to action and stiffening of the free borders. So basically you will see along the borders, you will see the pathology more, and you will see calcified nodules along with that. And often they're associated with regurgitation. So aortic stenosis and aortic regurgitation often will be together in rheumatic heart disease as compared to degenerative. You can also see aortic regurgitation in degenerative disease, but again, you know, one of the pathophysiology of rheumatic heart disease is that you will see regurgitation more commonly with rheumatic. And you will typically see mitral valve involvement also with rheumatic heart disease. So that is another point to take. So this is again a cartoon depicting the fusion of the commissures in rheumatic heart disease. As you can see, the commissures fusion is more prevalent here as compared to degenerative heart disease or degenerative aortic valve. Degenerative aortic valve is characterized by leaflet thickening and calcification, and the clinical factors that are associated with it is increasing age, male, hypertension, smoking, elevated cholesterol. So all the traditional risk factors for coronary artery disease, you know, you can also see in patients who have degenerative aortic valve stenosis. And in this, you would see mostly nodular calcified masses on aortic side of cusps. You won't see any commissural fusion, and free edges of cusps are not involved as compared to rheumatic heart disease. So as you can see in this cartoon, there is calcified nodule mostly on the aortic cusp. The commissures are relatively free. They're not fused. And you would see these kind of calcified nodules in the degenerative pathophysiology. This is just a simple slide or simple cartoon depiction of a general approach to aortic stenosis. If you see aortic stenosis, if you see mitral valve involvement or aortic regurgitation quite a bit, then consider rheumatic etiology. If you see isolated aortic stenosis without much of aortic regurgitation, then you see what the age of the patient is. If they're less than 70, then bicuspid aortic valve should be a consideration. If they're more than 70, then degenerative or calcified aortic valve stenosis. So what happens in aortic stenosis is there's obviously an outflow obstruction because the left ventricle, whenever it pumps, because of the resistance offered by aortic valve or resistance, so there's a LV overload that leads to concentric hypertrophy of left ventricle, decreased LV compliance, increase in diastolic pressure, or enhanced left atrial contraction to maintain the LV filling. So you will have left ventricular hypertrophy, left ventricular dilatation. So this is the normal, in normal situation, the cartoon on the left-hand side, you would see LV and aortic pressure about similar in normal flowing valve. And the picture on the right-hand side, you would see LV pressure is much more as compared to the aortic pressure. The LV pressure in that picture is almost 200 by 25. Aortic pressure is 110 over 75. So that is how the gradient across the aortic valve happens, because LV has to generate a lot of pressure to pump the same amount of blood through that calcified aortic valve or severely stenotic aortic valve, leading to such a difference in valvular gradient. Physical findings, as most of us already know, that we hear a diamond-shaped crescendo decrescendo murmur because of the stiffness offered by the aortic valve, the resistance offered by the aortic valve from LV to aortic valve. So typically you would hear in right, on the second right intercostal space radiates to the carotids, and sometimes it radiates to the entire precordium. And as you can see, in mild to moderate aortic stenosis, the peaking of the crescendo decrescendo murmur happens much earlier. And as the aortic valve progressively calcifies or gets more and more stenotic, the peak of the murmur shifts more towards S2. So as the murmur, the peak of the murmur shifts, it means that the aortic stenosis worsens. So that is something that we can see in our physical examination. So again, you know, some of the important points: intensity of the murmur does not predict severity. Presence of thrill does not predict severity. Late peaking murmurs predicts the severity of the aortic stenosis, because as the valve progressively calcifies, you know, it takes more and more time for the aortic valve to open to force the blood past the lesion. And again, you know, in physical findings, we typically see a delayed pulse. It's called parvus et tardus, normal pulse. You would see rise and fall normally, but in aortic stenosis, again, it takes a longer time to peak because of, again, you know, it takes a longer time to push the blood out of LV into the aorta. Echo is the most important and cornerstone of diagnosing aortic stenosis. That is the most important tool that we have to diagnose aortic stenosis. Of course, there are other means. We can do coronary angiogram, much more invasive. We can look at the gradients across the aortic valve using a catheter as well. But these are more invasive measures, and they can be done only when there's a discrepancy in echo measurements and the gradients that we measure by echo. And, you know, if there's discrepancy, we can do catheter across the aortic valve. But again, echo for most of the practical purposes, echo is the most common and important tool to assess the severity of aortic stenosis. So in echoes, in echo, we usually look at 3 parameters: velocity of the aortic valve, mean transvalvular gradient, and valve area by continuity equation. Again, this is, it's not a moving picture, it's a still picture, but there's normal aortic valve on the left side and there is a calcified aortic valve on the right side. You can see the haziness and everything associated with calcified aortic valve on the right side of the picture. This is just a different view. This is a short axis view. You can see beautifully the 3 cusps of the aortic valve on the left-hand side, and on the right-hand side, severely calcified. Again, these are echo parameters of how to measure the aortic valve area and transvalvular gradient. So let me see. Okay, so this is an important slide which depicts the severity of aortic stenosis. It's classified as mild, moderate, and severe aortic stenosis. Mild aortic stenosis is anything which has a velocity less than 3 meters per second across the aortic valve. Moderate is 3 to 4, and anything more than 4 gets classified as severe. We should also look at the gradients. Anything less than 25 is mild, 25 to 40 is moderate, and anything more than 40 is severe. When it comes to valve area, anything more than 1.5 centimeters squared is mild, 1 to 1.5 is moderate, and less than 1 is severe. And valve area index is also an important calculation when it comes to deciding aortic valve replacement. People who are big, we can do valve area index, centimeter squared by meter squared, and less than 0.6 is considered severe. Then there is one subset of aortic stenosis is patients who have low ejection fraction or small left ventricle. They are the subset called low flow, low gradient aortic stenosis. So in some of the patients, the valve area, the gradient, and the velocity across the aortic valve does not fit into severe aortic stenosis. However, they have normal or they have reduced LVEF. Say their LVEF is less than 50%, their LVEF is 40%. So those may have severe aortic stenosis and fit into the category of low flow, low gradient. Or if their stroke volume index is low, less than 35 milliliters per meter squared, then they are also low flow, low gradient aortic stenosis. And typically how we diagnose them low flow, low gradient state is to give them a dobutamine challenge or dobutamine stress echo. By giving 5 mics of dobutamine, we try to improve their LVEF to see what their actual gradient is. So in many of these patients who have low LVEF, if we give dobutamine challenge, their gradient across the aortic valve increases, and that is one way that we can diagnose these low flow, low gradient aortic stenosis. So the aortic stenosis, again, there is a classification, stage A, B, C, and D. Stage A is those who are at risk for aortic stenosis. Stage B, who have mild to moderate aortic stenosis. They are also called progressive aortic stenosis. Stage C are people who have asymptomatic, again, that is important, asymptomatic severe aortic stenosis who qualify for all the aortic stenosis severity. However, they're asymptomatic. They are again categorized as C1 and C2. C1 are the people who have normal LVEF, and C2 are the patients who have abnormal LVEF. This classification is important because there's a treatment algorithm that we follow based on this classification that I'll show you in a few minutes. And stage D is those patients who are severely affected by aortic stenosis, those of severe aortic stenosis, and they're also symptomatic. So stage D are the patients who would need treatment for sure. And there are some subsets of patients who have stage C who are asymptomatic but have severe aortic stenosis. Some patients in this category will also need treatment. So the important thing to remember is stage C and D. And I'll go over the treatment algorithm in just a few minutes. So let me just skip over to treatment algorithm. So this is, again, stage A is progressive, is at risk, stage B is progressive. So we don't need to remember stage A or B for now for treatment purposes. So the important subsets to remember are stage C and D. And again, as a reminder, stage C and D are those patients who both have severe aortic stenosis. Stage C are asymptomatic and stage D are symptomatic. So, so we've already established that patients have severe aortic stenosis. If you look at the left-hand corner of the screen, patients have severe aortic stenosis. They are symptomatic. Class 1 indication is aortic valve replacement. Stage D1, aortic valve replacement. Asymptomatic patients who are stage C, again, they are asymptomatic, but they have severe aortic stenosis. Then we look at other parameters. If EF is low, less than 50%, then there is a class 1 indication for aortic valve replacement. These patients who are, even though asymptomatic, who have low LVEF, they get aortic valve replacement. Patients who have severe aortic stenosis but are asymptomatic, if they are undergoing any other cardiac surgery, they are candidates for aortic valve replacement at that time, regardless of their symptoms. And then there are patients who have very severe aortic stenosis, who are asymptomatic, as manifested by velocity more than 5, mean gradient more than 60, and those who are at low surgical risk. So these are very severe aortic stenosis patients. Even though they're asymptomatic, there is an indication for them to undergo aortic replacement. The other thing that we commonly do in our practice is when we establish patients have severe aortic stenosis and they say that they don't have symptoms, we make them walk or run a little bit on treadmill to elicit the symptoms, because most of the patients think that this is a normal aging process and they're not having, or they are feeling fatigue or lack of energy because of normal aging process. But in fact, many of these symptoms can be resolved if they get proper treatment for aortic stenosis. So we can walk them on a treadmill, and if they develop a lot of symptoms, then that's an indication for aortic stenosis. Or if there is a very high rate of progression of aortic stenosis, then there is a very soft indication for aortic valve replacement. It's class 2B. So that means that it's a soft indication, can discuss with the patients, not a very hard indication. So for all practical purposes, the indications for aortic valve replacement is, of course, when they are symptomatic. Asymptomatic patients who are undergoing other cardiac surgery, who have low LVEF, who have very severe aortic stenosis, who get tired easily on treadmill, and who have, very advanced progression of the valve disease. Then there is another category of moderate aortic stenosis on the right-hand side of the screen, in which when we do echocardiogram, they fit into moderate aortic stenosis. However, if their LVEF is low, okay, then you do a dobutamine stress echo, and they might be one of those patients who are in low flow, low gradient stage. And in those patients, there is an indication to replace the aortic valve. So those are stage D2 and D3. So those should also undergo aortic valve replacement. And then there's another indication for aortic valve replacement in patients who have moderate aortic stenosis, who are undergoing any surgery. Then, of course, they should have their aortic valve replaced at the same time, even though they have moderate stenosis. So to sum up, symptomatic patients should undergo replacement. Subset of asymptomatic patients should also undergo aortic valve replacement if they meet certain criteria. And this is the same kind of slide that we already went. So in the interest of time, I'm not going to go over this, but it reiterates the same thing. I want to feature a little bit on the management issues. In these patients, treat hypertension as guideline directed. There's a concern that antihypertensives might result in a fall in cardiac output. However, it has not been validated in other or in a randomized controlled trial or even in studies. Diuretics, avoid patients on diuretics, especially if the left ventricle chamber size is small. Try to avoid diuretics. ACE inhibitors always advantageous to help with negative remodeling. Statin therapy you can give, however, it has not proven to be of any beneficial improvement when it comes to progression of aortic stenosis. So the last few slides I want to focus on aortic valve replacement. The goals of intervention in aortic stenosis are to relieve symptoms, enhance exercise capacity and quality of life, and prolong life expectancy. And aortic valve replacement is considered in all patients regardless of their age if overall life is greater than 1 year and there is likelihood of survival more than 25% with improved symptoms at 2 years after the procedure. So again, if the quality of life of the patient is acceptable, age should not be a factor. If someone who's 80 and who has a pretty good, decent quality of life, which is being hampered by aortic stenosis, I think it's reasonable to get a valve replacement in them. And I think the whole paradigm has shifted because of the transcatheter options that we have available now. So choice of intervention, the way we approach here is we always have a heart team approach, meaning that there's a shared decision between the interventional cardiologist and the CT surgeon. So there is a risk factor called STS Score Calculator in which we calculate the risk of mortality, renal failure. There are many different variables that you can plug in. There's a software that calculate the risk of the patients, high risk, moderate risk, and low risk patients. And depending on that, we can make further decisions. So again, low risk patients are those who have less than 4% STS mortality, medium risk are 4 to 8%, and high risk are more than 8% of the patients. Prohibitive risk is more, it's more than 10% or something. Again, this is an older slide. The management has shifted a little bit, especially because of introduction of newer trials called TAVR trial and Partner 3 trial, which I'm going to touch in a little bit. These are the transcatheter devices that are available for minimally invasive through the groin approach, transfemoral approach, most common approach for transcatheter replacement. Two most common valves are SAPIEN valve and Medtronic core valve. A SAPIEN valve it's in its 4th generation, SAPIEN 3 Ultra, and Medtronic valve is also generation, I think, Medtronic Evolute. And there's a newer valve that has been approved called Boston Scientific Lotus valve. All of them have their own nuances, but we can use any of these valves depending on patient selection and some of the patient characteristics. So I think what changed the whole situation in aortic valve replacement is the Partner trial that came out in early, I think around 2012 or 2011 sometimes. And that was for high risk or prohibitive risk patients. And it showed that transcatheter valve replacement was non-inferior to surgical aortic valve replacement or medical. So at that time, TAVR got approved for patients who are high risk or prohibitive risk. And based on the success of TAVR in these subset of populations, then there was trial for intermediate risk patients called the Partner 2 trial and the TAVR trial, which again showed that transcatheter valve was equivalent to surgical aortic valve replacement in patients who have intermediate risk as well. And based on similar steps, there was a partner 3 trial in which low-risk patients were enrolled. So based on the partner 3 trial, now transcatheter aortic valve replacement is approved for both risk, medium risk, as well as low risk patients. So for most practical purposes, the patients who are offered surgical aortic valve replacement are typically younger patients. Reason being is because we don't have the very long-term outcomes of these transcatheter bioprosthetic valves. So if you were to given a choice between AVR via transcatheter or via surgical, usually we try to do surgical aortic valve replacement in younger patients, and for rest of the population, low risk, intermediate, or high risk, the treatment of modality is transcatheter, usually transfemoral approach. Limitations of transcatheter approach, again, stroke, paravalvular regurgitation. Many patients, or not many patients, I would say, but probably around 5 to 7% of the patients requiring permanent pacemaker. And again, the durability is always in question because we don't have long-term trials or long-term follow-ups, I would say, because I think this got started in an early 2010s transcatheter aortic valve replacement. So we have data, but we don't have data beyond that time. So durability still is kind of questionable. That's why our patients, we try to still do surgical aortic valve replacement if they're low risk. Again, 10-year results are encouraging, but again, we don't have results beyond that time. So I think that sums up, I wanted to make this brief and just wanted to highlight the main points on what we're doing here in terms of aortic valve replacement. Most of these patients, or majority of these patients, as I said, we are doing TAVRs, and some subset of patients we are doing surgical AVR. And most of the time it's a heart team approach. Any patient who has aortic stenosis, we have a CT surgeon, we have interventional cardiologist, and also a dedicated radiologist, and there's a shared decision. And that's how we come to a conclusion where would be the best approach for this patient. Usually transcatheter valves are done in hybrid OR, and pre-procedural imaging involves CT scan of abdominal aorta and iliac vessels as well. And most of these patients stay the night and they get discharged home the next day. So that is all I have to say for, for this presentation. And I would be happy to answer any other questions or any other comments that you guys have.
Over to chairpersons, Dr. S.C. Datta sir, Dr. Amrit sir.
Good morning, Mr. Shishir, Dr. Shishir. You must be in USA and it must be evening time right now.
Yes, it is. It is around.
We're having a wonderful morning over here in India, and we're celebrating our Independence Day. Today morning I was joined a bit late. I had to join for flag hosting at 2 different places. Okay, now I've seen your lecture, most of it. I joined from slide number 6 or 7, I think. And I think you've given a very nice detailed approach to management and treatment of aortic stenosis. I think, is there any way we can differentiate clinically between supravalvular aortic stenosis and subvalvular and valvular?
Most of the time it's imaging. Clinically, rely on imaging studies to differentiate between echo or CT scan. Most of the time we resort to CT, coronary CT, or ascending aorta CT. Most of the time it's imaging that we differentiate between these subsets.
Okay. Any questions from the audience?
Well, Dr. Murarka, do you ever go for transcatheter aortic balloon valvoplasty?
So as I get it, that you're trying to ask if there's a role for balloon aortic valvuloplasty.
Yeah.
Yes, absolutely. There's still a role of balloon aortic valvuloplasty. And typically we see in patients who See, the thing with aortic valve replacement is that after you do the aortic valve, they have to be on dual antiplatelet therapy for 6 months and aspirin thereafter. So there's a place for balloon valvuloplasty in patients who are surgical patients, like if they are to undergo surgery for non-cardiac causes, like if they are to undergo any other surgeries, and they cannot be on dual antiplatelet therapy for that surgery. So we try to bridge them with balloon aortic valvuloplasty, and then once they undergo that surgery, we bring them back for aortic valve, for transcatheter aortic valve replacement.
Now in D3 category, if there is one set of patient will be having normal ejection fraction, another one will be having abnormal ejection fraction. So what is the fun in differentiating between the two? Because you have to go for the valve replacement.
I'm sorry, Dr. Datta, can you repeat that again? That there's one patient with a normal LVF, one patient with an abnormal LVF.
Abnormal, that you are classifying in D3 category, stage D and D3. So why differentiate between once it is a normal, low grade and low
flow, low gradient. You're talking about low flow, low gradient.
Low gradient. Then you have two categories. One have with a normal ejection fraction, another one with a reduced ejection fraction. And in normal ejection fraction, you have abnormally low flow, which will be called a paradoxical, and that you go for a stress. See for that. Why exercise all these? Once you are having the low flow, low gradient, why not go for all cases for the aortic valve replacement?
So the whole point in trying to identify patients who have low LVF, what happens is that patients who have low LVF, their gradient, they don't generate enough gradient. So if you just look at the echocardiogram, some of these patients have in fact severe aortic stenosis, but because of the low gradient generated on echocardiogram, that's why they are not classified appropriately as severe aortic stenosis. That's why we need to give them a dobutamine challenge or dobutamine stress for them to generate enough gradient. Now, in terms of why it makes more importance in terms of treatment, usually there's a little bit of prognostic factor to it. Patients who have normal LVF, they do much better in terms of their outcomes as compared to patients who have low LVF and low flow, low gradient. So I think there is twofold importance of this. A, patients who will be prognostically doing better. And number two, just in identification of patients who have severe aortic stenosis.
Thank you. Thank you. Any other question from the audience? Maybe you are.
Dr. Kumar has got one question. He's asking which anesthesia is used for?
So we still use general anesthesia.
Can you please anesthesia for the transcatheter aortic valve replacement?
General anesthesia.
Okay, no, then I mean, okay, fine. What is the role of TAVR in bicuspid aortic valve with coarctation? What is the risk involved?
So, in bicuspid aortic valve, TAVR
with coarctation.
With coarctation. Again, I've not had experience with coarctation and bicuspid aortic valve, but I would say the approach would be very challenging with coarctation of the aorta. So it probably surgical, if patients are at prohibitive or they cannot undergo surgical replacement, then what we would run into issues with is approach, and probably we will try to use approaches rather than the conventional for TAVR in these patients.
Anybody else got any other questions?
Hi, Dr. Shishir.
Yes, sir.
Dr. Lal here.
How are you?
This is the platform we are interacting and Jaggu is arranging. Very nice presentation.
Thank you, sir.
Very nice presentation. I'm just having some query about the patients who are having a low risk and intermediate risk. So in India, we have an approach like if the patients are surgically unfit, then only we consider TAVI.
Right.
But as per the partner 3 trial, you can consider these patients as well.
100%. That's what
So
in fact
so guidelines has not considered yet, or they are in the process of considering them as well.
So the guidelines are usually lagging behind after FDA approval because guidelines come after every few years.
True.
Partner 3 trial got approved, or it was presented last year, 2019 at TCT. So it's FDA approved for low risk patients, but guidelines, as I said, it will come in the next guidelines. So we are doing it for low risk patients.
Yeah. Yeah. Another thing I wanted just to tell you that in India also we have one valve that is called My Valve. I think you have heard about that. So that got CE approval, but I think it hasn't got approval yet, FDA approval. But it has a good result and it has been published in Euro PCR also, presented over there also.
Yeah, again, I think there are
more
valves in Europe as compared to US. US, there are 3 valves: Sapien, Medtronic, and Lotus. These 3 have approval. The other valves are there. There are more kind of valves in Europe, as you said, who have approval there as compared to US.
Yeah, but you use more of a retrievable valve or another valve like Lotus valve?
Mostly, Lotus is a new entrant to this field, and the Lotus, it's not available in all sizes. And Lotus valve typically has a high rate of pacemakers. So Lotus valve, again, more popular are Sapien and Medtronic. Lotus is just a new entrant to this field.
Very nice to see you.
Dr. Shishir, there's one question from Dr. Jamila. There are a few cases in which TAVR and TAVI was done simultaneously. What is your take on that? Is it a good approach in patients where surgery is not feasible? TAVR for coarctation.
So TMVR, again, it has been using the aortic valve in mitral position. Some of my mentors have used it. Again, if patient is at prohibitive risk, then I think it's worth giving them this option.
Okay. Anybody else? Any other questions, please?
Dr. Murarka, do you have anything to do with the calcification scoring in the management strategy? And furthermore, as most of your patients are elderly, do we have to go for the coronary angiography routinely?
Yes. All patients who undergo TAVI, we do coronary angiogram first. All patients.
And calcification.
Coronary angiogram first. And fix whatever is needed on coronary. First, we fix the coronaries and then we take them for.
Calcium scoring, does it have any role in this treatment strategy?
Sir, you're echoing, sir, Dr. Datta. So you're saying calcium scoring has any
role in defining the strategy for treatment?
Not really. I mean, calcium score is going to be very high regardless. So calcium scoring, I don't think it plays much role in terms of defining a strategy. Of course, calcium score, it helps if, we do a CT scan of femoral arteries, iliac arteries approach all the time, and we want the vessels to be more than 6 to 7 millimeters for transfemoral approach. So again, if we see a lot of calcification there, then yes, to define an alternative approach or to fix even the iliacs first before we do the TAVI.
जब तक पथरी निकलेगा नहीं, कहाँ पथरी है? गॉल ब्लैडर में है, किडनी में? कितना mm का, कितना दूर में है? कितना दूर में है? हाँ, मोने पूछ रखी, घर कितना दूर में है? कितना दूर?
Any queries? Any further queries?
Hello. Good morning, everybody, and good evening, Dr. Shishir Murarka. I'm Dr. J.K. Mitra from Ranchi. So everything was fine. It was a very nice talk and very informative talk, I must say. And we learned a lot of things. But what I saw in this talk, that we are based mainly on the investigation part. And here the patient usually comes when the symptoms are there. So can you just highlight few symptoms like syncope or all these things, which force that and which indicate that the disease is severe?
The three major symptoms are syncope, shortness of breath because of heart failure, and anginal chest pain. These are the three symptoms.
So which one is more cardinal, where you should go for that further investigation is needed and the patient needs some interference?
I think all of them are important. I mean, if we have patients who have valvular aortic stenosis, if you're having patient who's having dizziness, that needs replacement. If they're having anginal, I think all of them are important. But I think heart failure, shortness of breath, that to me, again, I don't want to discriminate between the symptoms, but heart failure, shortness of breath, that is very important.
Which one you do prefer, that valve replacement by open or TAVI, or this balloon balloon arteroplasty?
So balloon angioplasty is only a temporary bridge. Okay. So the definitive treatment would be surgical or TAVI. Usually nowadays, TAVI in patients all across the high risk, intermediate, or even low risk.
Yeah, that's fine. Yeah.
Choice. In younger patients, you can do surgical aortic valves because, again, we don't know the long-term durability of TAVI.
Right. Thank you. Thank you. Thank you very much.
Thank you.
Anybody else has got any queries, please?
There is a question, I guess. Do these patients after TAVI need lifelong antiplatelet? And if not, how long you give the antiplatelet agents? And do they need endocarditis prophylaxis before dental procedure after having TAVI? Two things.
So, so endocarditis prophylaxis, no. Second thing is second was antiplatelet therapy, aspirin and Plavix for at least 1 year, and then they can be on aspirin thereafter.
Anybody else got any other queries, please? Thank you very much, Dr. Vineet. Giving the mic back to you. Dr. Vineet?
Yeah, yes.
Holding back the mic, giving back the mic to you. Thank you very much, Dr. Shishir. Thank you very much, Dr. Datta.
Thank you so much, everybody, for your participation.
Yeah.
I request Dr. Kejriwal to kindly felicitate Dr. Murarka with medallion and a certificate of honor as a star speaker of the conference.
Thank you very much, Dr. Murarka. And I cannot give it to you physically, but I think Dr. Vineet will make some arrangements to have you delivered.
No, thank you again. It was a good platform, and again, it was very nice and an honor and privilege to be a part.
Yeah. Okay. Dr. Vineet, please hand over to him as it's possible.
Yeah, sure. I also request all our chairpersons to kindly accept a certificate of faculty. Dr. S.C. Datta sir, Dr. Kejriwal sir, Dr. Lalchand Daga, and Dr. Indira Panda. Thank you so much for your time and patience. We would like to have some words from our chairperson, Dr. Rajesh Rajan. Dr. Rajesh Rajan.
Thank you.
Sure.
Thank you very much, Dr. Shishir Murarka. Wonderful on aortic stenosis. Thank you very much for joining with us. Hopefully we can meet during our national conference ISCC con, probably after this COVID pandemic. We'll surely meet, and it was wonderful academic feast from your side. Thank you very much for joining.
Thank you again. Thank you again, everybody.
I must salute our faculty who are at COVID duty also and attending this conference. Thank you so much, Dr. Panda, for sparing your time. We have a short break for tea and we'll join you back in